All right, Shuttle DPT back with another anatomy breakdown, muscle by muscle. This time we're giving some shine to Teres Major. Not a rotator cuff muscle, but it is in close proximity and definitely deserves a spot in your mental map of that posterior shoulder. Pretty commonly referred to as latch little helper, and for good reason. It's not a rotator cuff muscle, but it plays a big role in our shoulder mobility mechanics, especially for stability and those big pulling movements. So let's break it down: origin, insertion, innervation, function, and a few good clinical pearls. Teres Major's name gives us some good information on what to look for anatomically. Teres being Latin for rounded and major indicating it's the larger of two muscles. Teres Major sits just below Teres Minor, a similarly shaped muscle of the rotator cuff. Aside from name and shape, Teres Major and Minor don't have too much in common. They do completely different things. Teres Minor is one of our four rotator cuff muscles, and its primary function is external rotation. Teres Major is very notably not a muscle of the rotator cuff, and it functions to produce internal rotation, adduction, and extension. So just like the latissimus dorsi, very similar to the lats for sure. They even share the same insertion point, so we mentioned the memorization technique in the lat video, lady between two majors. Pec major inserts in that lateral lip of the bicipital groove, lat dorsi into the floor of the bicipital groove, and then Teres Major has the most medial insertion on that medial lip of the bicipital groove. So easy to understand what we might call it lat's little helper. Similar actions, similar insertion, they work in conjunction with each other, and those upper lats and lower Teres Major fibers run parallel to each other. So good team right there. So just to keep hitting on origin and insertion, that bicipital groove is prime real estate for those big internal rotators. Teres Major, the lats, pec major, all insert right there, and in that specific medial to lateral order as well. So keep that in mind. Our origin is going to be that inferior angle of the posterior scapula along that inferior third of that lateral border. So that lower chunk of that lateral edge, posterior scapula. From there, the fibers run out laterally and superiorly, wrapping around the humerus anteriorly, also anterior to the long head of the triceps, and inserts into the medial lip of that bicipital groove. So keep that in mind. Definitely another helpful note for differentiating it from Teres Minor. Teres Minor inserts posteriorly on the greater tubercle, while Teres Major, we see, comes around to the anterior humerus and again inserts into that bicipital groove. Also worth mentioning, we've got another piece of that quadrangular space here. So Teres Major along with Teres Minor, the humerus, and that long head of the triceps makes up what we call the quadrangular space, which is where the axillary nerve and that posterior circumflex humeral artery pass through. Teres Major is that inferior border of our quadrangular space. Noteworthy for sure, definitely not uncommon to hear about axillary nerve compression in that area, so do make sure you know that. But yeah, origin is that inferior angle of the posterior scapula. And again, our insertion, lady between two majors, we're right on that medial lip of the bicipital groove. We mentioned Teres Major does internal rotation, adduction, and extension of that humerus, of that shoulder. work synergistically with those lats. We've got EMG studies that show that teres major and the lats activate together. So the action of pulling something towards your torso or reaching behind your back, it's a big helper in all of those pulling movements, pulling exercises, pull-ups, rows, lat pull-downs. You're thinking lat first, but teres major is definitely doing its work as well. Basically like a mini lat dorsi. Also has a little synergy with the rhomboids. In order for teres major to act an extension of the shoulder, it'll rely a little bit on the rhomboid muscles to stabilize that scapula. So they'll sort of pull the scapula in the opposite direction of teres major. So a bit of a balancing act with some of those bigger movements. Sort of cool. You can add rhomboids and teres major into the muscles you're working when you do your lat pull downs for sure. A little bit of everything. That's a really, really important like multi-muscle movement for sure. We're going to be innervated by the lower subscapular nerve roots C5 and C6. Teres major is not near as greedy as that subscapularis. As we know, subscapularis is going to be innervated by both the upper and lower subscapular nerves. Clinically, that's a nice section to know because if you have an injury to the lower subscapular nerve, you're probably losing function in both subscapularis and teres major. Just to reiterate, teres major is innervated by that lower subscapular nerve and roots C5 and C6. Lower subscapular nerve, C5, C6. When it comes to injuries, isolated teres major tears are pretty rare. Most of the time you see strains or overuse syndromes in overhead athletes, especially throwers, baseball guys, possibly swimmers and volleyball players as well. Just any athletes doing those big, powerful adduction, extension, internal rotation movements. It can also be involved in posterior shoulder tightness or those abnormalities of scapular movement. To that point, from a rehab perspective, it's worth paying attention to in those patients with limited overhead mobility, that rounded shoulder presentation, those lat dominant guys. Sometimes it gets short and it'll limit flexion of the shoulder or elevation, especially in our big bodybuilding guys. They'll go in there, they'll do 1 million lat pull downs. That teres major is definitely working too, right? We know how closely related those two muscles are. A good needling muscle for that reason. A little bit of a safety muscle because of how close it is to the rib cage, but definitely one that I find myself needling a whole lot. It's interesting with the needles. I've seen guys get a ton of overhead range of motion back just from trigger point needling in that teres major. There's a cool dry needling study with teres major, specifically in handball players. So a nice like overhead type sport. Study took 30 men, younger guys, 18 to 30. They had shoulder pain, they had restrictions, and of course, presumably from handball, right? Half of those guys, really one time, one treatment, got all of the trigger points, got a few good twitch responses, and when they reassessed afterwards, they found that pain during the throwing action had decreased significantly. Internal rotation range of motion had increased. Tissue stretch had improved. So a lot of good benefits from one dry needling session to teres major. So yeah, cool stuff, very cool stuff. Very strong modality, powerful modality. When you see those type of overhead restrictions, you definitely do want to consider a little bit of that needling or just some sort of trigger point technique, right? And then that'll do it, right? So that's your teres major breakdown. Quick and easy. Lats, little helper, internal rotator, big player in pulling strength. Not rotator cuff, but still very, very important for shoulder function, posture, performance. So keep that one in mind. Next up, we're going with the rhomboids major and minor. And afterwards, I think we're going to go to levator scapulae. So starting to spread out a little bit. Like, subscribe, comment below if you learned something new or have questions. If you hated it, tell me how much you hated it. More to come. Treadle DPT. I'll catch you later.